Okay, thank you, Ramona. And thank you all for joining this morning and being able to reschedule from last week. I really appreciate you being here. Before I start, I just want to provide a trigger warning for anyone who might want to not stay present, as I will be talking about mental health and serious mental illness, as well as suicide and death among those with mental illness. And so just a heads up about that. So here's a brief overview of my talk. In the first half, I'm going to talk about definitions and the distinction between mental health and mental illness. I'll talk about the burden of mental illness and how mental health is a part of public health. And my intention is not to present new or novel ideas, but rather to remind us and to shine a light on mental health in the context of public health. Then I'm going to follow with a presentation of some results from a current study that I'm working on. So this quote is often misattributed to former Surgeon General David Satcher, to the National Institutes for Mental Health Director Thomas Insel, and even to President Barack Obama. But in 1954, it was Dr. Brock Chisholm, the first director of the World Health Organization, who famously said, "There's no health without mental health." And I would extend that to say that there is no public health without mental health. So here's a couple of definitions of mental health from the World Health Organization, the Centers for Disease Control and Prevention, and the Healthy People 2020. And these three definitions generally revolve around the ideas of well-being, of coping with normal stresses and challenges, and the ability to be productive. And in conversation, we tend to talk about mental health and mental illness, but there's two noteworthy things to mention. The first is that these terms are often used interchangeably as if they mean the same thing, but they don't mean the same thing. And the other thing to think about is that they're sometimes thought of as two opposite ends of a spectrum, so mental health and mental illness. But mental health really refers more generally to well-being and how we feel, while mental illness refers to diagnosable disorders that affect a person's mood and thinking and behavior, and these often impair functioning. Mental illness can be isolated, it can be episodic with remission and relapse, or it can be a lifelong chronic condition. I think it's helpful to think of mental health as something we all have, like our physical health. And mental health can be good or it can be poor, just like our physical health. And while we all have mental health, not everybody has a mental illness. So poor mental health and mental illness are both problems to be addressed by public health. And so to be clear, in many cases today, I will use the term mental health to encompass both mental health and mental illness. And I'll use the term mental illness when I'm speaking specifically about the mental disorders. So the causes of mental illness are still inadequately understood. And what I'm going to briefly say here is an entire oversimplification. But there's general agreement that mental illness is often caused by some level of interaction between biological, psychological, and social factors, as well as heredity. For serious mental illnesses like schizophrenia or bipolar disorder, there's usually a genetic predisposition. However, not everyone with a genetic predisposition moves to a full-blown mental illness, but it's the interactions of the genes with other biological, psychological, environmental, and social factors that actually can produce that mental illness that actually comes out. In other cases, mental illness can be a result of various combinations of these above factors. So mental illness is a serious public health problem. It's prevalent, with an estimated 20 to 25% of adults having a diagnosable mental disorder in a given year, and 46% lifetime prevalence for having any mental disorder. And unfortunately, only half of all people with mental disorders actually get the treatment that they need. Mental illness is not specific to any one group. It affects all ages, genders, racial, ethnic, and cultural groups, and all socioeconomic statuses. Mental illness is also a leading cause of disability in the US and worldwide. Specifically to public health, mental illness correlates with health risk behaviors like tobacco and substance use, physical inactivity, and poor eating habits. It also influences the onset, progression, and outcome of other health conditions such as heart disease and diabetes. And finally, mental illness is a huge economic burden in that it costs the US an estimated $300 billion annually. Mental illnesses also have an earlier onset than other chronic diseases. 50% of all mental illness begins by age 14 and 75% begins by age 24. And the average delay between onset of mental illness symptoms and treatment is on average 11 years. In terms of access to mental health services, 46% of adults with mental illness received no treatment in 2020. And 11% of adults with serious mental illness had no insurance coverage in 2020. Over 155 million people live in a designated mental health professional shortage area. So what is the role of public health when it comes to mental health, or what is public mental health? Well, APHA, the American Public Health Association, states that public health works to protect the health and wellness of people and communities. So assuming that mental health is a component of overall health, a comprehensive public health must consider, address, and attend to mental illness prevention and mental health promotion. So one place to start is by looking at the four-step public health approach. The first step is that we need to identify the magnitude of the problem. The who, what, when, where, why. And some of that is established, but we can also use existing public health surveys and surveillance systems to do some of this, as well as adding some adaptations to these systems that are more specifically related to public health, mental health. Second, we need to identify the risk and protective factors. And again, many of these are similar to risk and protective factors for physical diseases that are already being monitored with public health surveys and surveillance systems. But again, we could add some questions more related to mental health using a mental health lens or analysis from a mental health perspective. Next, we can use this information to develop and test prevention strategies. And these can be at the individual level, the community level, or at societal levels. Finally, we assure widespread adoption, and we make sure that these effective interventions are implemented. And some examples might be the school-based interventions or workplace-based interventions. We can also apply a public health prevention framework to address mental health, where primary prevention focuses on preventing mental illness, secondary prevention focuses on preventing the progression of mental illness, and tertiary prevention focuses on preventing relapse and the associated outcomes. So given the early onset of mental illness, there may be opportunities to prevent the emergence of mental illness or prevent progression. As early as prenatal care and critical developmental periods, and also by addressing social determinants targeting specifically those that are thought to impact mental health earlier in life. Another view of the public health approach is through the 10 essential services. And the 10 essential public health services, organized here by the 3 core functions of public health, are shown, and it's easy to see how they can be applied to mental health just as they are to physical health. So it's everything from assessing, monitoring, and investigating risk factors to developing policy that impacts mental health to assuring equitable access to mental health services. So public health is considered relatively recent, as mental health has historically been siloed from physical health. And relatively recent, we're talking about decades rather than perhaps centuries. So I want to briefly mention a couple of historic reports that aim to encourage public health action for mental health. So the Surgeon General's report that was released in 1999 was the first on mental health, and it called at that time for the full integration of mental health into the nation's public health system. So this report concluded that mental disorders are among the most prevalent and costly conditions in the US, and that effective treatments can reduce the prevalence and decrease the adverse effects on other health conditions. In 2011, 12 years later, the CDC released the Public Health Action Plan to integrate mental health promotion and mental illness prevention with chronic disease prevention. And it suggested 8 strategies for this integration. Here are the 8 strategies for the integration in this plan. And again, we come back to the importance of surveillance, epidemiology, and research, as well as education and communication and integration of mental health programs and policies through our public health infrastructures and our systems. The report emphasizes that health promotion, prevention, research, education, policy, all have to transcend the outdated separation of mental health from the rest of one's health. Fast forward another 10 years to 2011, or 2020, sorry, where we've made progress, but we still have much work to do. And this was more than 20 years after that Surgeon General's report, and there's still a call for public health to address mental health. So for example, in 2020, there was an article published in the CDC journal Preventing Chronic Disease, where the authors laid out the need for a population approach to mental health. And you can see how public health plays a role in all of these. And so this proposed population approach framework includes using data and science to inform policies and programs, preventing where possible and intervening early, intervening at the community or population level, not just the individual, using partnerships to reach broad and diverse audiences, and taking a life course approach to target specific age groups where things may be different. Using a holistic approach, being culturally sensitive, honoring community wisdom and creating solutions, and championing equity by addressing systemic issues and social determinants of health. So the CDC is a part of the US Department of Health and Human Services, and it is the nation's leading science-based, data-driven organization that protects the public's health. And as a leading public health organization, the CDC really should take an active and visible role in addressing mental illness. But in 2021, just 1 year ago, former NIMH Director Thomas Insel wrote a piece asking, why is the CDC missing in action on severe mental illnesses? He argued that the CDC has historically limited their emphasis on mental illness. So for example, the Morbidity and Mortality Weekly Report, which is a publication of the CDC, it reports on death and disability statistics from numerous causes. And while anxiety and mild depression are sometimes reported, serious mental illness, which affects over 14 million people in the US, is generally not reported. He further points out that the CDC reports on infectious disease deaths across the country weekly. However, suicide death statistics until very recently lagged by 2 years. And so it's also important to note that the prevalence of serious mental illness and access to mental health services is largely reported by the Substance Abuse and Mental Health Services Administration, or SAMHSA, which is a service agency. And it, comparatively to the CDC, really lacks the epidemiologic and analytic capacity. So as an example of the disconnect, deaths of despair, which are deaths from suicide, overdose, and alcohol-related diseases, likely surpassed 175,000 in 2020. And this is more deaths from any infectious disease except for COVID, and more than any type of cancer except for lung cancer. But this is only a rough estimate since there's no real-time surveillance system for tracking deaths of despair. So there's this old adage that you can only manage what you measure. And this is particularly relevant for public health, because if we're not monitoring and measuring it, we're not going to know that we need to address it. So now, speaking specifically to epidemiology, which is one of our specializations here in the NDSU Master of Public Health program, although psychiatric epi has actually been around for decades, but it's been mostly in psychiatry and done by psychiatrists. Integrating public health and epidemiologic approaches to mental health has only been more recent. And when we look back to the core functions of public health, surveillance and epidemiology are two essential services. And this would include monitoring population health and mental illness. It would also include applying our analytic capacity to investigate those risk and protective factors, causes and consequences, and disparities. So referring back to the Public Health Action Plan, EPI again is one of the strategies for integrating mental illness and mental health into chronic disease prevention. And again, we're talking about the analytic capacity to investigate risk and protective factors and to investigate relationships to physical health conditions and chronic diseases. And referring back to the population approach to mental health, we can use data and the best available science to inform our public health policies, our programs, and allocation of resources. Relatedly, I did want to quickly note that there are a number of data sources already that exist that can be used for public mental health surveillance and mental health or mental illness epidemiology. And all of these are based on samples of the US population, a representative sample of the US population. So as I mentioned previously, the only comprehensive source of data on mental illness comes out of SAMHSA, which is the service agency that lacks that analytic capacity. Most of the national data on mental health come from surveys that are run out of the National Center for Health Statistics. And this includes healthcare surveys, which are samples of records from ambulatory care clinics, from emergency rooms, and survey data that's linked to some health insurance data. It also includes the National Health Interview Survey, which is a nationally representative sample of a self-report survey. And it includes a number of variables related to mental health. And occasionally it'll include some mental illness, but it's all self-reported. Finally, there's studies on mental illness that use data from hospitals and clinics, but those are typically clinical studies, and those data are typically not publicly available. So to summarize, poor mental health and mental illness are serious public health problems. And much about mental health promotion and mental illness prevention can and does fall under the purview of public health. So in some ways, public health already does address mental health related issues, but it's often less visible or invisible. And a public health approach and prevention framework for physical health conditions can also be applied to mental health, as we saw in the public health essential services and the prevention and population health frameworks. But more than 20 years after the Surgeon General's report calling for the full integration of mental health into our nation's public health system, the plea continues for a comprehensive public mental health, which I think many would agree is still yet to be achieved. So I want to make a few last comments on the visibility of public mental health. And mental illness and mental health are often combined with substance use under the umbrella of behavioral health. And this is one way that mental health becomes invisible. Other examples are that many schools of public health do not include mental health in their curriculum, not as required coursework or even as electives. In many states, mental health falls under the Department of Human Services rather than the Department of Health, which is similar to the split between the CDC and SAMHSA. And DHS is like SAMHSA, tends to focus more on provision of services for mental health and substance abuse than actual research, surveillance, and those sorts of things. But I do think we can raise the visibility of public mental health. We can integrate our mental illness prevention and mental health promotion with our disease prevention activities. We can use a mental health lens to identify those risk factors, vulnerable populations, and comorbidities. If we're not looking at those things, thinking about mental health, we're not going to see those relationships. And we're not going to be able to put that out there in a visible way. We can also report on serious mental illness in addition to the other mental health and mental health care reporting that we do. And by better highlighting the mental health work that we already do, we can start to raise that visibility. So now I want to switch gears completely to present results from a mental disorder epidemiology study that I'm working on with co-authors Dr. Leslie Lamb, who's an assistant professor of practice in our Department of Public Health, and Dr. Stephen Wunderlich, who's an adjunct professor in our department and director of the Center for Biobehavioral Research at Sanford. So if you read articles about mental health and mental illness, it's commonly stated that people with mental illness die 10 to 25 years younger than the general population. And after seeing this over and over, I wanted to know the source of this statement. So I dug into the literature, and what I found was that every citation cited some other article that made the same statement. I could find no data to back up this claim. So finally, after digging, this probably took months. I discovered the source was a report from 6 state health departments that was published in 2003, and it examined years of potential life loss for those with mental illness. And so that said, it made me curious as to whether this was true for the nation overall and whether it was still true 20 years later. Studies from around the world indicate generally people with mental illness die 10 to 20 years younger, but these studies come from comprehensive population-based national health registries, and we don't have anything like this in the US. We also should keep in mind, I'm going to say it now, and I'll probably say it a couple more times, but half of premature or early deaths in the US are due to preventable factors. And so this includes many unhealthy lifestyle and unhealthy behaviors. It includes injuries and deaths by suicide, all of which are preventable. So we asked ourselves, do people with mental illness in the US die 10 to 25 years younger than the general population? And our objectives were to look at patterns of premature mortality for the nation, to identify leading causes of death for those with mental disorders, and to look at age of death for those with mental disorders. Our data source was the US multiple cause of death files, and these are the death records for all deaths that occur in the United States. Our subsample that we used included just US adults 18 years and older who died in 2018 and in 2019. Our primary measures were causes of death and psychiatric diagnoses, and ICD-10 codes were used to classify the causes of death, and this included the underlying cause of death as well as other contributing causes to death. ICD-10 codes were also used to classify psychiatric diagnoses. For analysis, we used analysis of variance to compare average ages at death by disorder group. So I want to take a minute to briefly explain documentation of causes of death. So causes of death are listed on the death record in terms of their proximity to the death. The most recent or immediate condition is listed first, and other conditions that gave rise to that immediate condition are listed chronologically. The actual mechanism of death, like cardiac arrest, is not listed as a cause. So the underlying cause of death is the last condition in that chain of events that led to the immediate cause of death. And this is defined by the World Health Organization, and it's the standard for death classification used around the world. There are also documented up to 20 other significant conditions that contributed to the death. So here's the cause of death portion of the death certificate. And so you can see the lines for the immediate cause and then the sequential causes, each of which impacted the one above it. Let me show you an example specifically. In this case, the immediate cause is hyperkalemia, and it's documented as caused by noncompliance with dialysis, which was caused by end-stage renal disease, which was caused by type 2 diabetes. And so in this case, the underlying cause of death would be classified as diabetes. So our results. We found that 1% of US adult deaths had a mental disorder documented on their death certificate. And using that, we identified 5 distinct groups by comparing those with documented bipolar disease, disorder, schizophrenia, and depression alone or in combination with one or the other. So the distinct groups that surfaced are those with no mental disorder, those with depression alone, those with bipolar disorder alone, those with bipolar disorder plus depression and or schizophrenia, and those with schizophrenia with or without depression. Records with other mental disorders were excluded from our analysis. So a quick look at demographics by mental disorder group. Here are the sex distributions by disorder group. And the most notable differences are that schizophrenia is overrepresented by males, and depression only and bipolar disorder only are slightly overrepresented by females. For race and ethnicity, here we see that the depression only and bipolar only groups have the highest proportion of non-Hispanic whites at around 85%, while the schizophrenia group has the lowest proportion of non-Hispanic whites at about 67%. Particular differences in marital status across the disorder groups included that over 1/3 of the depression only group are widowed, and nearly 2/3 of the bipolar plus group and 3/4 of the schizophrenia group are separated or divorced. The no disorder group had the highest proportion of married at about 37%. In terms of manner of death, 90% or so of the no disorder and schizophrenia groups died of natural causes, but only 2/3 of the bipolar plus group died of natural causes comparatively. The depression only group and the bipolar plus group had a more notable proportion of deaths by suicide, as you can see with the purple bars, purple part of the bars. So our primary findings of interest revolved around age at death. And we started by looking at years of potential life lost, similar to that report from 2003. So years of potential life lost is a measure of years lost due to death occurring before the age of, in this case, 79. And I used 79 for this as it was the life expectancy in 2019. And so you can see on the bar chart that the mean years of life lost for the no disorder group was 5, while for depression only, it was 6. For the bipolar disorder, it was 12 years lost. For bipolar plus, it was 20 years lost, and schizophrenia was 12 years lost. The table below shows the mean age at death. And notably, the bipolar plus group's mean age at death was 58 years old, and the bipolar only and schizophrenia group's mean age was about 66 years. So this bar chart shows the percent of deaths by disorder in each group. And notably, there's a substantially higher proportion of deaths in the younger age groups for the bipolar plus group, while the majority of the no disorder and depression only groups live to 80+ years. And so you can see the big difference of where right from the beginning, we have a much higher proportion of those deaths, notably. Another way to visualize this is through histograms showing age at death distributions by mental disorder. And you can see that the no disorder group has a relatively low level of deaths up until the age of about 50, where it starts to rise. The bipolar plus group has a substantially higher level of deaths from 18 to 50 years old, higher up until about the age of 50 compared to some of the other groups. So here's a comparison of the age at death distribution for each disorder laid over the distribution for those with no disorder. And this one is the depression only group compared to the no disorder group. And you can see that they're relatively the same. This next one is the bipolar only group, and you can see where the ages begin to depart right about the age of 50. And this one is the schizophrenia group. And again, you can see them start to depart at the age of 50 and increase up to 70, but then they really drop off. And finally, the bipolar plus group, and this really visualizes the early deaths that occur for this group compared to the no disorder group or any of the other groups, really. So analytically, we then compared the mean age at death overall for each of the groups compared to the no disorder group. And the rest of the table compares each disorder to one another, which we were not interested in for these analyses. We found statistically significant differences for all disorder groups compared to the no disorder group. And so we asked ourselves, are there specific causes that contribute to these age differences? So you can see that the differences between the groups, almost 8 years younger for the bipolar only group, 15 years younger for the bipolar plus group, and 7 years younger for the schizophrenia group. And this is the overall age at death. So what we found was the leading causes of death themselves were generally similar across the groups. But one distinct difference was that in the no disorder group, fewer than 1.6% died by suicide. And while suicide is the leading cause of death for the bipolar plus group and the depression alone groups. So this table shows the rank order of cause of death by mental disorder, and you can see similarities in many of the top 5 causes. So the no mental disorder, that's sort of our reference group here with the top 5. And then you can see that Alzheimer's comes into the top 5 for the depression only and the schizophrenia groups. Diabetes comes in for the bipolar only and schizophrenia groups. And suicide comes in for the depression only, the bipolar only, and the bipolar plus groups. And you will also notice that nearly 14% of deaths in the depression only group and 21% of deaths in the bipolar plus group are due to suicide. So we then examine the age at death for the mental disorder groups by selected underlying causes of death. And depression only was never notably different from the no disorder group, so I'm not going to mention it going forward. For heart disease, the 3 other groups range from 9 to 15 years younger at death, with notably bipolar plus being 15 years younger than the no disorder group. For cancer deaths, all 3 disorders were nearly the same at 6 to 7 years younger at death compared to the no disorder group. For unintentional injuries, the bipolar plus group is much higher at 9 years younger than the no disorder group, while the other disorders were much less or even inverse. For respiratory disease deaths, all three disorders were significantly younger, with bipolar only and schizophrenia at nearly 10 years younger, and the bipolar plus group at 13 years younger at death than the no disorder group. For death by suicide, the three disorders range from about 4 years younger to 7 years younger at death. And so while these are all significantly younger at death, they're not nearly as different as some of the other causes of death. For stroke deaths, mean ages at death range from 7 to nearly 11 years younger for the three disorder groups, with again the bipolar plus group being nearly 11 years younger, while the bipolar only group at 7. And finally, for diabetes deaths, as we've seen with all other causes, the bipolar only and schizophrenia groups are higher at around 7 years younger. And the bipolar plus group, again, has the highest or greatest difference from the no disorder group at 12 years younger at death. So our general conclusions are that after 20 years, the overall pattern is generally consistent with the previous statement, with those having mental disorder dying about 10 to 20 years younger than those with no disorder. And this is consistent with the foreign studies. We also found that increased incidence of suicide in those with serious mental illness is not the primary reason for these differences in age at death. Finally, we saw that those with bipolar disorder with another serious mental illness have the most striking patterns of early death. So there are several limitations that I want to acknowledge. First, data from death certificates vastly underestimate mental illness, with only 1% of the nation's deaths having a documented mental illness compared to the 20 to 25% prevalence of any mental illness found from other surveillance methods. Second, mental illness classification is only those with a diagnosis. So there has to be a clinical diagnosis documented in some medical records, and that diagnosis or that medical record has to be available to the medical examiner. Other limitations are that we did not account for other comorbid mental illnesses or substance use disorder. Also, without a comprehensive health registry system, we do not have any information on health services, medications, and the like. So we can't look at any antecedents or treatments or covariates like that. And finally, our findings here are based solely on the underlying cause of death, and other contributing causes are not analyzed. So how is this relevant for public mental health? Well, this is an example of using epidemiology to examine an issue around serious mental illness. And we know that many modifiable risk factors for premature death in those with mental illness come under the purview of public health. So again, up to half of premature deaths overall are preventable. And it's said that roughly 35% are due to behavioral factors. So healthy lifestyle is really important, and those unhealthy behaviors are correlated with mental illness. Injury prevention, we can examine patterns of injury deaths in those with mental illness and identify injury deaths that are particularly notable in those with mental illness, especially if they're different from the general population. In suicide prevention, I'll just note that not all suicides are by people with mental illness, but death by suicide is strongly correlated with mental illness. And so we can monitor and report on suicide in those with mental illness as a particularly vulnerable group. So in the end, public mental health efforts to prevent mental illness and promote mental health through investigating causes of death could contribute to prevention of some of these premature deaths. So I'd like to close with sharing this quote. Dr. Irving Selikoff was a renowned researcher and tireless public health advocate, and he's best known for making the link between asbestos and lung disease. But decades ago, he made the observation that statistics are people with the tears wiped away. Now, I'm a PhD trained epidemiologist, so I lean toward data, research, statistics, and I like to think of statistics as an epidemiologic tool that can point public health in a direction to address some of these issues that produce the tears. So thank you. Listed on the right side of the slide are some resources for more information or for assistance. So I prepared for a 45-minute talk with 15 minutes of Q&A, so I'm done.
Well, excellent timing on that, Dr. Johnson. That was really great background information and really fascinating study that you have been working on with your co-authors, and really appreciated how you laid out your results. That was really tangible to kind of follow through. So really great. I'd like to open it up to questions. And if you want to put your question in the chat, or feel free to unmute yourself and ask Dr. Johnson directly. And I'm going to tolerate a few moments of silence while people are thinking of their questions. Well, while others are thinking, I am curious if you have, I guess, a hypothesis about why the bipolar plus is the group that is seeing the most significant impacts compared to the other pairings.
You know, I think bipolar disorder in general is a serious mental illness that provides a lot of difficulty in controlling. And when you add another serious mental illness to that, you've sort of got this, what I would guess would be sort of an exacerbated interaction between the two when you've got so many different things that you're trying to manage. And so, yeah, so I don't have a good answer for that. I just think that the combination of the serious mental illnesses in one person probably leads to more difficulty.
Yes, and that's not a requirement in epidemiology that you have all the answers either, but I was wondering.
No.
Here's a question from Dr. Meyer. What is your take on treatment centers using tobacco or nicotine products in light of these results and the physical health connection? Could we do better? And if so, how?
Are you meaning treatment centers? So treatment for mental illness using tobacco products?
Yeah, I can clarify. So in the health promotion world, there's been this battle between people with maybe a substance use disorders getting into treatment centers. And so that's one aspect. I know it's not the same as the mental illnesses you're talking about. However, many times, and I know you didn't touch on this, tobacco products and nicotine products are used as coping mechanisms in an unhealthy way. And it's kind of been this approach, again, historically, that that's okay, that we need to allow this type of unhealthy coping mechanism in a variety of places around mental health. And wondering if you have thoughts on that, again, seeing the connection to physical health and heart disease and how tobacco products can relate to those.
Yeah, I mean, I guess I think about, and I know you'll hate me for saying this, but I do think about the harm reduction sort of approach to some of this, but I do think we can take a next step and a better step. If we're trying to address healthy lifestyle, as you said, I mean, this is a big one. And if we're looking at particularly these early causes of death, and we haven't looked at them epidemiologically before. We haven't looked at these sorts of relationships. It might be that we're not realizing the impact that we're having by not addressing it more forcefully. So could we do better? I think we could do better, especially if we know that some of those really premature deaths are due to things that are related to tobacco.
Yeah, that's an interesting question, Dr. Meyer. I was kind of trying to think more about those associations as well. And my thinking goes back to connections between childhood adversity and some of these, the prevalence of these disorders in that group across the life course, and the research that they're doing around maybe mechanisms like inflammation. I'm just really seeing some parallels in terms of, it'd be interesting to see if we had a way to control for nicotine and tobacco use, if we would still see those same associations. And in the ACEs literature, they do still see those relationships. But I think the point that Dr. Meyer's making is very well taken. Are there other questions? Yes, Dr. Meyer commenting, it could be some progress to be made using lifestyle medicine. We have a question or a comment from Jacob Davis. Thank you for sharing. I am a survivor of suicide, having lost my brother to it, and a survivor of attempted suicide, and know how hard it can be to deal with depression and anxiety. As I learn more about the history of Indigenous people, I start to understand the interconnectedness of that loss of culture, community, and connection. What do you feel would be a good way to show that loss and impact due to cultural genocide, assimilation, and acculturation? And more specifically, about the knowledge being shared about the boarding schools and the bodies being found, and what impacts that will have on survivors and their families.
Wow, that's a great question. Jacob, could you say a little bit more about what you mean about a good way to show that loss?
Can you hear me?
Yep.
Okay. Just wanted to make sure. I think for me, it's just I know there's a lot of anxiety, especially when it's coming out about bodies being found and things like that. And I'm just wondering, looking at it from like that Indigenous perspective and understanding kind of that historical context of why boarding schools were created, and the history of them in itself, I think is meaningful. But how do we acknowledge and address that in a way that's not doing more harm or triggering, I guess would be my question. Like, what's a good way to approach, I won't say research, but just like from a communal perspective, how do we approach that in a good way, based on some of the expertise that you have?
So I am self-admittedly a data and numbers person. But I think this would be something that would benefit from some qualitative research to try to get some, from an Indigenous perspective, using Indigenous methods, try to better understand how that fits together and be able to present that more culturally appropriately. I think it would be good to acknowledge that in other not similar, but other sorts of historical trauma and historical grief as being part of that risk factor in the first place, and part of the ongoing trauma. I'm not a qualitative researcher. I wish I knew more about it because I really do feel like understanding the thoughts, the thinking behind what people are seeing and feeling when these things are coming up would be the route to go with that. And I know Dr. Danielson is a qualitative researcher, and I don't know if she's got something to say about that.
I do definitely appreciate qualitative research, and I think, you know, when you're saying you're not an expert, that's why we get to work in teams and get people who complement one another's expertise. And I agree that this is something. I agree with your response completely. I think that's a very useful way, and just being a data person who acknowledges that the quantitative data can't necessarily answer all of those questions. I think that still makes you a mixed methods person. Open to mixed methods research, at least as being necessary to answer.
You're right. I definitely need a partner.
Yeah. Jacob, what do you think of Dr. Johnson's thoughts on that? Does that resonate?
Yeah, and I think there are other groups kind of looking at that, just like the National Native American Boarding School Healing Coalition does a really good job about sharing those stories and looking at it from that healing perspective. But I always find myself within the, you know, like realm of my job, always having to educate others about kind of that history. And so I know that oftentimes kind of triggers emotions and things like that. And so I'm just wondering, like, you know, as we look at it at a national level, and this stuff starts to become more apparent and that history is kind of brought up more, like, how do we approach that in a way that's going to protect the people that could be harmed by it the most, especially when it comes to, like, the depression and anxiety effects of it?
Yeah, Jacob, I don't have a good answer for that.
It sounds like an important research question, Jacob, that
Yeah.
we can form a team around with you. I chuckle just because you have lots of good ideas and then you get brought into more projects, but other comments or thoughts on the research presented, the degree to which the CDC is maybe not yet meeting its obligations with respect to mental health? Any ideas on how, listening to Dr. Johnson, how, you know, you might be able to integrate the mental health component into your public health work? Even though we're not a huge group and I think everybody's very friendly, there still seems to be a dampening effect on dialogue in these type of venues. In the future, we could consider small discussion groups or something for some topics like this. Well, thank you all very much for taking the time to come and learn about Dr. Johnson's research and that important connection of mental health within our public health work. So I hope you all have a wonderful weekend.
Thank you all for coming.